Hi all, welcome to AETCM YouTube channel. Today we will have an interesting case, that is a neonatal constipation case. Over to you.
Thank you, sir. Sir, a 3-day-old baby, adequate for gestational age, tame baby, has been referred to outside hospital with a complaint of intolerance to feed and not passing stools for the past 48 hours, sir. When I went and inspected the baby, in initial 10-second assessment, I did my pat triangle, sir. Appearance wise, tone is normal, but the intermediate consolability and the look and gaze appears normal, and child speech was continuously crying and slight irritability is there. In the appearance itself, I was not able to notice a grossly distended abdomen, sir, with the dilated veins. Then breathing but breath sounds were normal. Position of the spine and
airway.
Pardon, sir?
Airway.
In the airway, I will clearly mention in the primary survey. Just in pat triangle, breath sounds were audible, position appearing normal, chest retractions were noticed, and flaring was also noticed, but no gasping, sir. In circulation, no mottling, no cyanosis, and CRT was more than 2 seconds. So it was
How will you
initial
examine CRT?
Pardon, sir?
How will you examine test the CRT? Capillary reflex.
Sir, usually we examine on the thumb or the distal limbs. We will be pressing the nail pad and releasing after around 2 seconds. Then if there is a sudden filling of the pink color, then within it is less than 2 seconds and it is within normal limits. Okay. It means there is an adequate perfusion.
See any other places?
And then heel,
over the sternum or forehead. And these are an ideal places instead of the fingernails. Okay.
So then I went to the primary survey, sir. In primary survey, child airway is appearing patent, no oral secretions, and no gurgling sounds, nothing was audible.
So why do you think about gurgling sounds?
In neonates, a chance of oral secretions because child is having an intolerance to feed, vomiting, aspiration, and everything we can expect.
So this child, especially the abdominal distension. So more chances of gastric content or bowel content may be coming here. So when you are mentioning about in the airway, already NGT is present or not?
In the airway, when an NG tube was already not around.
Just involved in the airway.
From the referring hospital itself, it's placed.
See, what are the things you have to keep in mind about NGT is whether NGT is put, what is the size of the NGT, whether it is in correct place. So all these things, as soon as you receive the child, like the endotracheal tube, you have to examine. And functionality. So usually they put the tube and then close it. So that will cause more regurgitation. Okay. Then it will be causing more aspiration then. So it should be always left open. Sooner you are coming and receiving the patient, you have to deflate the stomach by gentle suctions or using a syringe. We have to suck it out. Whether they have done on the end route, we do not know. So immediately we have to deflate. That will help in 2 aspects. One, it will prevent or minimize the aspiration. Number 2, it will ventilation will be better. So the diaphragmatic splinting action will be avoided. Okay.
This child's NG tube was already connected to a bag and it was
but then functionality we have to check.
Continuous aspiration.
Sometimes the tube may get blocked or it might have come out little like that we have to.
Then I went to the breathing, sir. Breathing, air entry is there bilaterally equal, no added sounds. Child is maintaining a saturation of 99% in room air with a respiratory rate of around 55, sir. For this child of tame baby of...
Yes, as I told you, have to confirm the position of the right tube.
Right tube. Actually, we took the X-ray and we saw the position, sir. That I will tell you as an adjunct to the primary survey. And breathing but child but chest.
Where did you auscultate? How the newborn baby? What is an ideal site? How will you auscultate?
Sir, auscultate usually we should have an either we can use the bell side of the
pediatric
stethoscope or bell side of our adult stethoscope can be used. Usually we have to examine especially the axillary area.
Axillary area. Why?
Sir, thing is that infant neonates, the lung maturity may not be adequate, sir, and some amount of collapse, everything can be there. So, auscultating in the upper area, we may not miss the collapse or the immature lung, sir. So, maximum distal part should be auscultated. The
conduction from this area, this lung, we may be having the auscultation sound, especially small babies, thin chest wall. So, in order to avoid, go far away from axillary, infra-axillary region is the ideal this thing.
But some chest retractions were noted,
Okay.
nasal flaring were noted at that time.
What is the rate of respiration?
Around 55, sir.
55, okay. Good.
Right now, since child is stable, I went to the circulation part, sir. In circulation, baby's NIBP was recorded, and it was coming around to be a systolic BP of around 40. It was in the around the 50th centile of the for this baby, so it was okay. And CRT was also less than 2 seconds. Pulse rate was around 180 per minute, sir. That was also an acceptable range.
What is the saturation in room air?
98, 99. Then I went to the disability, sir. We assessed the neonatal GCS score was assessed. E4 was there, opening spontaneous. Verbal response, cries, only 3 was there because cries persistently to pain. And motor, 6 normal was there. So around 14/15 was there, GCS was there, sir. Pupils were bilaterally reactive. GRBS was also checked at that time. It was around 99 milligrams per deciliter. It's also in the acceptable range.
GRBS is more important.
And in exposure, I checked the peripheries. Peripheries were warm and pink, and temperature was also recorded. It was around 37 degree Celsius. And anyway, we call a blanket was already given, and the warmer was also we kept open at a temperature of 37 Celsius.
Now, how will you maintain the body temperature? What are the easily available gadgets and sophisticated equipments?
Mother's lab,
Kangaroo mother care is one.
Mother's lab.
Mother's
Okay, then.
most important is that giving an adequate blanket, we can give thermo-regulated
So covering the
blankets.
head, this is the most surface area is compared to body, head surface area is more. So many times we see the children's head is being left uncovered. So especially in pediatric we have to cover. Gamgee pad. Warmed Gamgee pads are the ideal if nothing is available. So in a bigger institute we are having everything. So this should be done. So thermoregulation is most important. Okay.
So I reassessed the primary survey. Child was remaining okay, but in view of respiratory distress and to see the respiratory distress, I took an ABG, sir, and anyway took an X-ray also. We took an X-ray babygram, and the X-ray the position of the NG tube is normal, but the lungs appears little pushed up, maybe because of the severely distended abdomen. And in the abdomen also, we were able to see dilated bowel loops were there, mostly the large intestine part, but no pneumatosis intestinalis, nothing was there, or any errant diaphragm or any other air shadows were detected. An ABG was also taken in view of the severe respiratory distress that we have noticed, but ABG was remaining more or within normal limit, normal pH and bicarb.
Two things you have to remember is, one regarding respiration, these types of children will go for periodic apnea.
Yes, sir.
Apneic spells.
Apneic spells.
And it may last few seconds or it may be extended period. So this should be, a history should be taken, and then you have to be careful about observation part. So we have to periodic. See, it is lasting for a few seconds, no problem. It's a persistent loss in it. Then we have to appropriately take care of the child. Okay.
Any other thing in the ABG other than the acid-base disorder? We looked into?
Electrolytes also we used to check, sir. And electrolytes, potassium was 5.3, sir. Sodium was 123. Calcium was, ionized calcium was 0.88, sir. So in the acceptable range. And sodium we rely on the lab sodium, which came to actually normal. So and glucose also already 98 was there in the same. So I went to the secondary survey. In secondary survey, no history of any allergies or medication. Child was already started on ampicillin and amicacin and metrogel from the outside hospital.
Why they start antibiotics? Is it necessary?
There was a recorded from the event history. There is a recorded event of fever on the day 2. So in neonates, even a single spike of fever they treated as sepsis. So they start triple coverage antibiotics, sir.
See again, one more important thing is, these children might be going for an aspiration chances, more chances. So better given earlier antibiotic coverage in order to prevent lung infections also.
So in medication, child was already started on antibiotics. That was the medication history. Then even lead to this baby is a G2 P1L1, second baby of a 28-year-old lady, adequate for gestational age, baby delivered by an LSCS, indication was previous LSCS, and post delivery child cried immediately after birth, Apgar score at the 5th and 10th minute were 10 out of 10, and child was normal, but child was feeding properly on the day 1. From the after the 28 hours, the child developed feeding intolerance with multiple episodes of vomiting, sir. For the next 24 hours, they observed the baby in view of persistent vomiting. They started kept the child on NPO, started on IV fluids. In view of fever spikes, they have started an antibiotic. X-ray was suggestive of dilated bowel loops. That's why they are referred to higher center, sir. That was the event for which meconium actually they have documented as passed, but not adequate for the feeding child has taken. Some amount of greenish stools they have passed, but not an adequate and frequent, hardly one episode per day.
Was a catheter test was done?
Pardon, sir? No, sir, in outside hospital was not, but in our hospital, after the child was brought to NIC, we did.
Oh, we did it, okay.
So that was the event leading to
simple, well lubricate and gently pass a small round tipped catheter, rubberized it is okay. Whether it is going through or some. And another thing is this type of children may be having other associated congenital anomalies, maybe cardiac problem, peri-Robin syndrome. So many other anomalies have been recorded and reported. So you have to look for other anomalies present or not. Okay.
So then we did the head to foot examination. Head of the baby's size was within normal limit, with the normal pupils, no congenital cataract, with no normal nasal cavity, no cleft lip, oral cavity, everything within normal limit. We examined the neck. Neck was also within normal limit, no swelling, no dilated veins, nothing was detected. Chest also appears normal growth for the baby, but chest retractions, as earlier as I mentioned, it is still there. Normal symmetrical growth of the upper limbs and lower limbs. Abdomen was grossly distended, umbilicus pushing towards outward with dilated veins over the abdomen were noticed. Bowel sounds were present, but bowel sounds were present. Examination of the cardiovascular system, but no massive murmurs were there, and later confirmed with echo that the PD is closed. That was the respiratory CVS.
What's the relevance of telling no structural abnormalities?
Actually, it may be any congenital genetical abnormalities might be there, sir. Child developing with any cleft lip or any other any congenital disorders, we have to rule out, sir.
And bowel sounds, you want to elaborate more, like
bowel sounds frequency in case of initial obstructions, the frequency of the bowel sounds will be increased, sir. To that opposite area, bowel will be continuously constricting, but at a particular point of time, the constrictions will gradually reduce and go into ileus, sir. But right now,
there is a head-sprung disease. But there will be any chances megacolon is there?
Sir,
motility will be there or not?
No, motility was there when bowel sounds were there, but I will gradually come to the conclusion. So, in view of, so I came to the provisional diagnosis that babies came with possible distal bowel obstruction with some amount of respiratory distress secondary to the distension of the abdomen, sir. This was my provisional diagnosis. So, initially in the ER, the child was...
Did this patient have any access?
Yes, already an IV access is secured from outside hospital and it is still patent. Child was having an ongoing 10% dextrose ongoing. So I continued with that.
You should have mentioned that also. Okay.
Since the child is having suspected intestinal obstruction, I kept the child NPO. I continued the maintenance IV fluid, 10 ml per kilogram of 10% dextrose was continued, and an antibiotic of another shot was given. We continued the same antibiotic, amikacillin and gentamicin and metrogel were continued, and along with after consultation with the neonatology, they said not to give any antiemetic. So because in neonates only erythromycin is the only drug proven to be given, but since child is NPO, nothing should be given. So any antiemetic or antiprokinetic agents were not given, and child was shifted to the NICU.
So any thing for the respiration or oxygenation, any interventions have been done from ER?
As if now there is no further increase in respiratory distress or any desaturation, so nothing was done from the ER.
No oxygen administration also?
No, nothing was given. In the NICU, within the next 6 hours.
So that probably, right tube, so you have left it open?
Already Riles tube was there, it is kept open.
Right. And any other simple examination probably you can document and then monitor?
Sir, in respiratory abdominal section.
Okay, that is something simple, no?
Yes, sir.
Next you mentioned the effect of certain.
Urine output also more important. So this is one of the things
Yeah.
to show the perfusion pressure is adequate.
Then once the child was brought to the NICU, we replaced the outside lines with a new line, and routine blood investigations were sent from there, including a blood culture, and we started collecting the urine, and collecting type of tube was sticker it was applied, and along with that NG tube was also changed. A new NG tube was kept, along with the continuous aspirating suction was kept, not suction, open tube was kept. Left it open, it was kept, and then baby was shown to a pediatric surgeon, and we planned the baby for a barium enema. And but before shifting the barium enema, child started to have an increase in respiratory distress, so a bubble CPAP was started for the baby in view of respiratory distress with around 2 liter O2, and after that again tachypnea came down around 50, it was maintaining, and saturation child was maintaining around 99 per minute, and no episodes of hypoglycemia, no other events were there. Then child was taken up for barium enema. In barium enema, it was shown that the distal from the sigmoid to the rectum, all the parts were highly constricted, and proximal to that area, bowels were dilated, sir. But any contrast pickup was there. So with a provisional diagnosis of distal bowel obstruction, child was then taken up for OT on the. No, sir, I was not there. Before my posting day, it happened. And within next 24 hours of admission of our baby to our hospital, child was taken up for surgery. They proceeded with a colostomy from the distal part they sent for biopsy, and the colostomy was done. Then baby was shifted back to NICU system, and the biopsy provisionally came as possible a Hirschsprung's disease. The ganglion cells were not detected, and the child was started on oral feeds. They have started around initial feed of 90 ml per kg per day. Oral feeds they started giving. Baby is tolerating it. The baby started passing stools, and currently child is symptomatically far better. Abdominal distension has come down. We were able to completely stop the bubble CPAP, and maintaining saturation room air with a normal vitals. Antibiotics, since we were asked to continue till for next 7 days, till 7th day of the antibiotic course. This is the condition, and the provisional diagnosis a case of Hirschsprung's disease.
So basically, constipation nearest wholly broadly classified.
Constipation.
So this will fall into the broad classification of constipation, right? Basically, you have the functional and the organic.
Organic.
Okay. Most of the time it used to be functional. And otherwise, organic means basically you are going to find some
pathology.
Okay.
So the orifices you have to examine. Okay. Congenital, anal. And oxygen administration. Suppose the saturation is maintained on room air. You want to enrich the oxygenation. Is there anything extra precaution you have to take in this field?
When we start oxygen for neonates, going beyond 2 liter O2, we should be careful, because even more than that will act as a continuous CPAP action to the baby, and the child can have abdominal distension. So up to 2 liter we can safely give.
Not only abdominal distension, the child may go even for barotrauma.
So if you are going more than that, secure an NG tube also, sure that abdominal distension is
Any other complication due to hyperoxia?
Then retinopathy of prematurity is another important complication. Since it's a tame baby, we are not
bronchopulmonary dysplasia also may happen in premature babies. Okay. See, what about the carbon dioxide estimation?
Carbon dioxide.
CVT what to monitor in pediatrics.
In neonates, hypercarb is more acceptable, but hypocarb we should be very, very careful, because even a mild amount of hypocarb, cerebral perfusion can reduce drastically and cause ischemic injury to the brain.
Okay. Permissible.
Permissible hypercarb is more acceptable.
More acceptable. So oxygen saturation, what is the target value they recommend?
Target it should be more than 94, sir. But as for NRP, by 8th minute it should be between 80 to 85. By 10th minute it should be more than 95%.
See, it's above 90 is enough for this small child, pediatric neonates and all, in order to avoid the hyperoxia complications. Just minimal oxygen administration to maintain at least 90% and above. We need not have to try for 94%. Okay. So in nutshell, the most important thing you have to One, avoid any aspiration
Yes.
and decompression of the abdomen.
Yes.
Number 2, ventilation. Once you decompress, it automatically will be enhance the ventilator system. These are the 2 things you have to keep in mind. And in your armamentarium, if you want to maintain the child, if there is no facility in neonatal and all, you want to shift another hospital. Suppose you forget you are in Amrita. See what all things you will take into account.
In which pattern, sir?
No, you are in another Marcel hospital.
Oh.
You want to, this is a similar child is coming there, and you want to refer the patient to a higher center.
Then again the parameters like from the airway, breathing, circulation we will have to take care, sir. In airway, here we did a bubble CPAP, we are making sure that the abdominal distension doesn't get increased. So usually in the case of obstructions, if you give a non-invasive ventilation, the abdominal distension might increase. Since we had a continuous suction, we were able to give a bubble CPAP. So when we are transporting, we may not be able to do suctioning and all. So it is better to, if there is associated respiratory distress, to go ahead with the elective intubation, invasive intubation and shift the baby.
So early intubation is
should
mandatory.
be
Okay, any bowel obstruction in pediatrics,
so that it
more
will prevent
babies.
some amount
But
of
okay,
aspiration
see
also.
during transportation we cannot expect all the care. So better you protect the airway, and it will also promote the ventilation. Okay.
Then to prevent the air, secure the airway itself, to put an nasogastric tube and keep it open. It would be also
Continuous.
helpful.
Okay.
So
Periodic
that aspiration
suction in
can,
between.
aspiration can be avoided. Then again breathing, maintain a proper saturation with a proper respiratory rate adequate for that gestational age. Circulation also, always try to maintain the systolic BP. If any BP comes down, then we can challenge the baby with the crystalloids up to 10 ml per kg of normal saline can be challenged, followed by we can give an infusion. Either if it is first 24 hours 10% dextrose can be given, post 24 hours isolate P can be given as a maintenance fluid 10 ml per kg, and if not maintaining, we can initiate on anodrops. For neonates, first conventionally they use DOPA followed by dobutamine. If it is not holding, we can start on adrenaline infusion for neonates. Then disability, then GCS we have to always monitor. With that we should be cautious that neonatal modified GCS score should be used when we are calculating GCS for neonates. Then GRBS is a very important parameter in disability. Always make sure that neonatal hypoglycemia is less than 45. So hypoglycemia should not be allowed. If the child goes into hypoglycemia, then we can use 10% dextrose of 2 ml per kg. 10% dextrose can be given, followed by an infusion can be given, sir. Then hypothermia should be absolutely prevented.
Exposure should be very careful about.
And similarly, hyperthermia should be also with it. Associated Pyrex is there, we can give paracetamol. 10 to 15 ml per kilogram paracetamol should be there. And for the basic ABCDs that we have to take care.
And one of the ways to enhance the quicker decompression of the stomach, they advise after putting the NGT, periodic lateral tilt. Or sometimes keep the child in the left lateral and then sucks. Then keep in the right lateral and suck. So we will able to bring out, take out a lot of fluids from the obstruction. Some simple technique they are advising. Instead of keeping always supine flat. So if during suction,
Okay, sir.
it will promote. Okay.
Was there any enema attempted?
Actually, pediatric surgeon before going for barium enema, they attempted an loose enema also, but that time also only mild stools were there, abdominal distension did not come down. So they proceeded with surgical.
So the New Year discussion starts with a neonatal discussion. Okay, good. Well done.
Okay.
Good.
Thanks.
Thank you.